Good morning, good afternoon, everyone. I'm Jenny Murcia, and I'm happy to facilitate the following four conferences. Thank you to each of you for being here with us today. We hope that all of you and your families are safe during this complex time in the middle of COVID-19 pandemic. On behalf of the International Society of Pharmacovigilance, ISOP, we are very pleased to welcome to all of you to the ISOP Patient Safety Day event. The COVID-19 pandemic has unveiled the huge challenges and risks health workers are facing globally. Therefore, ISOP engagement is to develop and share these safety awareness sessions with the aim to increase safety use of medications. It is now my pleasure to introduce our President, Mira Harrison, who will address you with a few words.
Hello, welcome to this ISOP webinar on World Patient Safety Day. My name is Dr. Mira Harrison-Woolrich and I'm the President of ISOP. Thank you for joining us for this series of very interesting events to discuss what ISOP and our colleagues around the world are doing to focus on this very important day. World Patient Safety Day began in May 2019 at the World Health Assembly. All WHO member states endorsed the establishment of this day to be marked annually on the 17th of September every year. The reasons for this were quite outstandingly clear. If you look at these statistics that I've placed on the screen, there are many things that we really do need to address in pharmacovigilance. For example, 134 million adverse events occur every year in patients in low and middle income countries. 2.6 million deaths annually are due to adverse events. 15% of hospital expenses in OECD countries are due to treating patient safety failures. 4 out of every 10 patients are harmed in the community setting worldwide. So this issue, which is not just restricted to adverse events associated with medicines, but more generally to patient harm, it's not just restricted to hospitals, but also to community settings around the world. The aims of World Patient Safety Day are to recognise patient safety as a global health priority, to increase public awareness and engagement, to enhance global understanding of patient safety, and importantly, to spur global solidarity and action to promote patient safety. All of these aims, which were derived by the World Health Organization, align strongly with the missions of our society, the International Society of Pharmacovigilance, which is to protect patients from harm by promoting the safe use of medicinal products worldwide. I'd like to just tell you a little bit about ISOP because I realise that many of you tuning in today will not necessarily be members because we have opened up these events to everybody for free of charge. But our society, in summary, is an international non-profit making professional organisation aiming to promote drug safety scientifically, clinically and educationally in order to enhance all aspects of the safe and proper use of medicinal products. In this definition, we include all drugs, vaccines and medical devices. And I should say that includes drugs which are sold over the counter and herbal medicines as well. And we aim to cover all countries. We currently have approximately 800 members in approximately 100 countries worldwide. We have regional chapters in Africa, Asia, Europe, Latin America, Middle East, USA and Western Pacific. We also have a number of very active special interest groups. These webinars are being produced by our medication error special interest group, and we have other groups that discuss herbal medicines and women's medicines. So if you are interested in joining ISOP, there's plenty of ways in which you can contribute to drug safety by being involved in these regional chapters or being involved in the ISOP special interest groups. Do have a look at our international website, which is on the screen now, isoponline.org, and look at the membership page and do think about applying if you're not already a member. So I'd like to move now to how can we work together this year, 2020, to reduce harm to patients worldwide. Very important year in medicine safety with the current pandemic crossing our world. And then maybe the first thing to say is what we're all already doing here at this meeting is participate in these World Patient Safety Day events to start to learn what's happening worldwide in your country, in your region, and across the globe. So let's try to become educated, first of all, on all the key issues affecting patient safety in our countries. For example, are there issues with access to safe and effective medicines? Are there issues with medication errors, prescribing issues, or compliance issues? Or are there, and this could apply equally, special and specific safety issues with particular medicines, devices, or vaccines? The next thing we can do is to remember to report suspected adverse drug reactions to all medicines, devices, and vaccines. In most countries, there's a national authority where you can report any adverse event, and this information is available online. As I was saying earlier, this year is a very important year because of the pandemic and issues with vaccine safety and medicine safety. So think about joining a professional society such as ISOP to collaborate and share information with your colleagues. And the next and perhaps most important thing I have to say about this is to start some conversations about pharmacovigilance, about medicine safety in your pharmacy or your clinic. I'd like to just share with you now one example of what ISOP has been doing to start these conversations about medicine safety. Throughout this year, we've developed the image which is on your screen now, which is an infographic about using medicine safely during the COVID pandemic. This was developed by a group of us within the International Society of Pharmacovigilance, and we wanted to try to communicate 4 key messages about using drugs and other medicines at this time. And you'll see on your screen there are 4 areas that we have focused on about where you access medicines from, how to act on side effects of medicines, how to stay safe and healthy. This is a really important point because a lot of people actually start using medicines differently in times of crisis and pandemic. And lastly, being aware of fake news, of wrong information, and directing people to information sites which can be reliable and can be trusted. We also developed this infographic in several different languages, and I will just show you some of these now, because we are aware in our society, although English is the official language of ISOP, many of our members around the world, of course, speak different languages. So I'm just showing you now on your screen the infographic in different languages. And these are all available on our website, on the ISOP website, which is now on your screen, and they also can be found on our social media platforms. Please do take a moment to have a look at them. Feel free to download them, print them out, and use them wherever you can to promote patient safety in your country. So just to wrap up this introduction, as the webinars commence, please think about the following things. This day, World Patient Safety Day, is a really important reminder to all of us of the need for continuing work on protecting patients from harm in all countries, wherever you work. Do enjoy and learn from the presentations by the ISOP speakers and by our international collaborators during the series of webinars. The WHO estimate that up to 80% of harm to patients can be avoided. That's such an important statistic because it means there is a lot of things that we can do. So implement what you've learned in these seminars, take them back to your country and implement them in your healthcare community. And again, please consider joining ISOP, and we'd love to have you join us in our society and become engaged in all the activities that we have to offer. And the last thing to say before we start the programme of events is please remember that every day should be World Patient Safety Day. Thank you for your time, and thank you for listening, and I do hope you enjoy the remainder of the events.
Thank you for your attention. Now let us introduce our speakers for today. First of all, I would like to introduce Dr. Irene Fermont. She is physician, immunohematologist, pharmacovigilance, and bioengineering who has been dedicating her career to patient safety. With more than 25 years of experience, Dr. Fermont is founder and director of her own consulting company, IFC, in Israel, France, and UK. Her passion also led to the creation of the Israeli chapter of ISOP in 2013. Dr. Fermont will present her conference entitled Combining Tools, Methods, Artificial Intelligence, and Information Technology to Prevent Medication Errors. Please give a warm welcome to Dr. Irene Fermont.
Thank you, Jenny. I'm very happy to be part of this World Patient Safety Day and very proud to have a wide Israeli participation with very outstanding speakers. So I'm very happy to be there in the World's Patient Safety Day, and then as a very old member of ISOP, I'm very glad that we have taken this opportunity in ISOP to join the WHO World Patient Safety Day. And especially proud to present our chapter participation with 4 speakers. And I will start with presenting our multidisciplinary strategy, combining tools, methods, and artificial intelligence and IT to prevent medication errors. Since 2013, we have created ISOP ISRAEL chapter, and we have 2 directions, applied research and education. What is our agenda today? I will start with presenting the global approach of ISOP ISRAEL, and then in applied research, the 2 projects that we have led during 2018 and 19, and how we want to integrate in the future artificial intelligence in our strategy. Then we will present our educational programs and the challenge that we have met in creating this and this activity. Our global approach is the fact that we think that any complex system has to be multidisciplinary, and this is true for health system and for pharmacovigilance. So what we want is to create in ISOP chapter, Israeli chapter, we want to create a platform which will be both innovative and multidisciplinary. First, to share the experience and expertise of all the stakeholders, and to design technological and methodological solutions. What we want is really to have all stakeholders with us. What is our ecosystem? Our ecosystem is patient-centered, and we want to have all the healthcare professionals, but also from hospital and from community, from industry and academy, from HMO and also to have patients with us. And what we are doing with that stakeholders, first of all, education for professional and for patients, practice assessment in hospital and in community, integrated project implementation, tools and methods driven from artificial intelligence and IT, risk management and quality improvement. So this is a virtual quality circle that we want to implement in ISOP ISRAEL. How do we do that? We do that in doing some applied research and implementing some projects. So I will start with a 1-year experience in Hospital Mayana Yoshua. First of all, what is the strategy, our multidisciplinary strategy? So we have the drug safety practices that are held the core tools that we are using is the ISMP, Institute for Safe Medication Practices, and we are using the medication safety self-assessment. Then we have the AE reporting and analysis. We do that with the EV-Drug My E-Report mobile application and in using a safety pharmacovigilance database. Then we have our patient education that we are doing with NIDIMED's Be Medwise. It's a US organization which is dedicated to patient information and education. And in the future, we want to integrate the artificial intelligence, big data with Medaware and Data to Life. Medaware, we have the CEO of Medaware who will have a presentation later in this session. So 1 year experience in Mayana Yeshua Medical Center, a small hospital, 320 beds, 18 medical departments, and 32 outpatient clinics. I think that we have a very special thanks for Gila Lyon. She is a deputy head of pharmacy in Mayana Yeshua Medical Center. She was a project manager, the steering and part of the steering committee of ISOP ISRAEL, and she's really very inspiring. And she's now in maternity leave. So the first tool that we have implemented is ISMP safety self-assessment. They have several self-assessments, the eye alert medication, the antithrombotic therapy, oncology, community and ambulatory and hospital, meaning that we had to choose one of their the safety self-assessment, and we have chosen the antithrombotic therapy because we thought that this will be the easiest to implement because everyone agreed about this anticoagulant. So the timeline was the following. The first step was to set up a multidisciplinary team. Then we have to run the ISMP self-assessment. First, it was translated into Hebrew, and then we obtain a first score. With this first score, we know what are our weaknesses and what are our strengths. And then we are able to do a FMEA approach to prioritize what we have to correct first, and what is the most dangerous, and also what is the easiest to implement. And then when we have this prioritization, we can set up a CAPA implementation, corrective action, preventive action. And then when we have implemented all this preventive action and corrective action, then we can look at indicators for performance, and doing that in having a new score in ISMP. So how do we did we set up this multidisciplinary team? We have a core team with the people who are always running all the questions and all the project. And then for time to time, we are going to to some expert according to the kind of question that we have in the ISMP, and to the type of changes that we want to implement. So, for instance, the core team was Gila Lyon, of course, and myself. We have a pharmacist, we have people from quality, from emergency, MD, a nurse, and a risk management director. And then the experts that we were going from time to time, that were not with us all the time, were from all kinds of departments: nurses, QA, laboratory, pharmacy director, and hospital medical director. And it's very important this step is a very, very important one, because if we want people to adhere to our to this project, we must have them in this team. And that will not be something that comes from outside and that will be imposed on them. So what are the results? the first baseline score that we had was the following. You can see that the self-assessment is like a long questionnaire of 120 questions, and it's going in a very, very small details of all the pathway, the medication pathway. And you can see that we have the patient information, drug information, communication, drug storage, medical device, staff education, patient education, risk management, and then we have the score. What we see here in green is where we were not so bad. And in we can say that in yellow, it's not so good, we can say. So if we go to the details, I will just show you some examples. This is what we see. If we go to the information on patient characteristic, we see that here we have the core characteristic about prescribing, dispensing, administering, and monitoring. We had 64%. We still have space for improvement, but it's not so bad. And then the second characteristic, it's to monitor and manage therapy effects and adjust treatment plan. So we can see for each question where we stand. We have, for instance, when we go to our bad scores, we go to the patient again, we see that in the question, all the question about are the patient including as active partners with education about their medication or how to avert errors or to prevent adverse reaction, then we see that we have only 29%. So we know exactly where we stand. We have like an objective picture of the safety approach, safe medication practices in the hospital. We have also about all the transition from hospital to community and from community to hospital that is included in all these questions. So this is FMEA. I don't expect many of you to read Hebrew. It's just to show you that you can prioritize in red, orange or green what you have to do first. And then you can build your kappa. In the kappa, we have seen that this is what we have to do. We have to write protocols, to educate about protocols, and to share this protocol on the net, on the intranet. Then we have all the training about healthcare professional, patient education, the IT system modification about the system about the electronic medical record, and the medication reconciliation. So I have not put all the details, but for each item, we had at least 8 or between 6 to 8 actions to take. So this is one of example of the action that was taken after the kappa. The first score for the competency and staff education, after we had brought some corrective action, was only from 38 to 64. And about medication device acquisition use, we went from 20 to 60%. We still have to implement to improve, but at least we can have an objective view of what we are doing, which is a very good tool to motivate your teams. The second aspect of our work plan was reporting and analysis of the adverse event. So to do that, we have used an application, which is my e-report. We thank very much the EV drug company who has helped us a lot. And so then we have used my e-report application, and we have translated it into Hebrew, which was really not easy because it was just changing the way we are writing. And then we have set up poster and flyer for patients. And we had training on the safety database, and we have to train hospital staff and to manage the adverse reaction. For instance, this is one of my e-report. I have put it in English because I thought that it would be easier for you to understand. But it's a very quick and easy mobile application, which is existing in several languages. And this is something that you can use on your PC or your computer or on your mobile, and it's a free, of course, free internet. You can download it. It's free, and this is something that we have translated into Hebrew and which is now accessible in Israel. So when we report the adverse event on telephone, on my or on a computer, we have directly the adverse event is sent to the Ministry of Health in Israel and to our ISOP Israel safety database, which is also an EV drug database that was given to us. And so we have some places which are dedicated to different pilot center, and one is Mayana Yoshua. We have started to set up this poster in Hebrew. I'm going back immediately to English. And what we wanted to do is this infographics. It's to tell the patient that it is exactly like Waze. In the Waze, you share your data to help the whole community. So we have started to do this flyer, and afterward, when COVID happened, I've started to use it with COVID, but I can say that unfortunately we have not succeeded to use it. The third part of our work plan is the patient education. For that, we had a partnership with NeedyMeds Be Med White. It's a US non-profit organization which is funded by FDA. And they have a lot of different posters, flyers, pocket guides, video, and it's something that we can use, and we can translate and use it when we need. For instance, this is what we have done. We have taken their pocket guide and used them for pharmacists and for anticoagulant. For instance, we have highlighted that first, medication can save your life, and we have spoken about benefit and risk. And then we have spoken about questions to be asked to your healthcare professional. And then some precautions, for instance, if you are taking Coumadin, and the main risk and first symptoms with anticoagulants. So we wanted absolutely to balance benefit and risk so that people will be able to understand that it's very important not to stop your treatment. One of the things that NeedyMeds is doing is video. For instance, this one, just a few seconds. It's just how so, for instance, this month will be about drug adherence. full month in NIDIMED, BMED-wise to talk about the medicine and adherence. So they have a lot of different activities that we can share. So what were our objectives? The first objective was to really build a multidisciplinary team and to develop a strong safety culture in the hospital. I know that the hospital was very proud of what they have done. It has been presented in several congresses, and but is it something that is sustainable? It's still a question mark. We wanted to start with another high-risk therapeutic class of products once we have finished with anticoagulant. We are not yet there. And also to enroll other pilot centers in Israel, which is still not there. However, if we want to have an outcome assessment of what we have done, we can say that the things that have really worked well was the multidisciplinary team. The fact that we were able to really implement fully and translate the ISMP, to set up the FMEA in the CAPA, and to translate my e-report and to do the infographics. This was done because of leadership and the commitment of Gila Leon. So it's really a one-person. I hope I've been also very helpful on this project. I think so. The fact that we have been really multidisciplinary. The fact that we have an adhesion from the management team, from the hospital managers, the fact that the marketing of the hospital was also very convinced, because they have immediately seen how helpful it could be for the hospital image. And at the end, the medical team was convinced by the real results and have started to write a new protocol, and they were very happy with that. What was less good, let's say, we have not finished the CAPA full implementation. We have still some protocols to write and other things to do. We have not implemented my e-report fully, and patient education. We have not adopted high alert medication, other high alert medication, and we have not enrolled another hospital. Why? I think that first of all, we lacked additional resources. Everything was on Gila and me shoulders, and she had to do that on top of all her work in the hospital. So it's really one-person project, which is now in maternity leave. And when we have started the adverse reaction reporting campaign, we have encountered something which was very surprising for us, because people were afraid of their responsibility if they were saying to patients to report adverse drug reaction, which was really very surprising for us. And then we can say that the pharma industry was really not involved, and this is something that we are still waiting for. And then the COVID-19 came, and we were obliged to stop everything. Then I would like to tell you about the second project, the use of anticoagulant in a chain of community pharmacy, Superpharm. So this was the Superpharm is about 100 of pharmacy in all Israel. And it was a collaboration between Superpharm, PSI, the Pharmaceutical Society of Israel, and so this, some of the slides that you will see after that are from Alina Amitai, the president of PSI, and were presented in the symposium of ISOP ISRAEL 3-4 June in Tel Aviv last year. So the idea is that the community pharmacists are really the last rampart before drug intake. So it's the last one to help to prevent medication errors and drug interaction, and to advise the patient on the medication safe use. What are our objectives? To improve risk awareness in the pharmacy and in the patient, so to decrease the risk of anticoagulants. To set up a sustainable safety culture in the chain of pharmacy, and to show that the community pharmacist is very helpful, and to have an empowerment as a community pharmacist. So how did we do that? First, we had a training, the pharmacists of all regions on all anticoagulants with key messages. And we have explained, we have described the project, we have given key messages for patients. Then we had a communication on mobile application, flyers, poster, website, and digital media. Then on-site assessment, we have to highlight the drug interaction. So these were the key point that the pharmacist has to check and to assess when he has a patient in front of him with prescription of anticoagulants. So first, drug interaction, adherence to the treatment. How is the INR if the patient is under Coumadin? What is the injection method to check if the patient understands well the injection methods? And if he understands also what are the risks of stopping the drug, the risk of hemorrhage, and what are the adverse drug reactions if the patient has drug reaction. So the key messages to the patient was to check if he's taking OTC medication and that he has to avoid, to explain what is the bleeding risk, to take the blood pressure, to monitor the renal function, and to tell him don't discontinue. So this was the timeline from June 2018 to June 19. We started the project, trained the pharmacist, then went to implement the program into the pharmacy. And then in June 2019, we had the result which were presented in our symposium. So what is interesting in that during these months, during 5 months, we had 4,000, more than 5,000 consultations. And about 10% of the patients with anticoagulant dispensation were in this program. So the program that you will see is about this number of patients and this number of consultations. And you can see that according to these different fields, we had about 60% of adjustment to kidney function, drug interaction 18%, instruction to proper drug intake 29%, instruction for frequency of drug intake and dosage 26%, monitoring of INR 4%, injection instruction 7%. So it's a snapshot of the use of anticoagulants, of all anticoagulants. But more of this, we are able to see according to each kind of drug, what is the main field of consultation. First of all, we know how many consultation according to what kind of drug, and then according to the different drug, we can see the way where we have been obliged to have an action with the patient. So you can see that we have a wonderful picture of the use of each medication. So, for instance, we had 180 medication errors or problems which were detected, and we know exactly with which drug led to this detection of medication errors. So what was good and what was less good? First of all, I think it's a very original initiative. I have not seen anything like that, but perhaps you can tell me if you have heard of something similar. It's really it has really given some pride and empowerment to community pharmacists. It has given this picture of the medication used in the field, and so we had this website communication. So why it has worked so well? Because we have this collaboration between PSI, Superpharm, and ourselves. Because the pharmacists were willing to prove their worth, that they are really active healthcare professional and providing good advice. And we have also this commercial firm willingness, which is also something important. What was less good? And we see that the consultation was very efficient. Either it was slow or it was stopped. The documents for patient education was not really well distributed. The pharma industry was not there. And we are very far from setting up a new company. Why is it so? Because I think that it was a workload for the pharmacist to take his time and do the check, to check all the key points with the patient, and with a lot of patients waiting in the queue for their own medication. Because also I think that without the pharma industry, it's difficult to go on with this kind of project. And because the collaboration between PSI and Superpharm was not continued. And perhaps it will come back, but this is where we are. So now this is in the future what we want to integrate in our strategy. It's artificial intelligence and big data in collaboration with Medaware and Data to Life. With Medaware, the idea is that we Medaware, the solution of Medaware on the electronic medical record to detect errors in the medical or preventable adverse reaction in the electronic medical record, meaning that we will be able, when we will present our strategy to an hospital director, to say, you know, here you have something that we have been able to detect just with 4 or 5 questions that we have run. So this is something that we can do much more extensively. The second possibility is to be able to have an assessment of the clinical outcome, because every time that we are going to an hospital, they are asking, are you able to measure if we have less medical, if we have less adverse reaction? It's a very difficult question to answer. So what we have what we could be able to do is to measure the adverse event rates before and after implementation of ISMP and Kappa. And then we can also issue reports to the department, the medical department, where we must act in priority, meaning that we can tell them we have detected some weaknesses in this and this department, so this is where we have to start doing our Kappa. And last but not least, we will be able to detect in the electronic medical record, to detect adverse event, and then we would like to have a connection between the MedAware solution to the safety database, our safety database that could be sent immediately. So this is our future, but we are working on that, and we know that we can do that on a technical point of view. Then a second about life, using artificial intelligence, we can be able to do a timeline logic, meaning that we can find the D0 of the first prescription. So we have the exposure date, which is sometimes very difficult to obtain. Then we can go back 1 year and look for all the diagnoses and all medical history of the patient. And then we screen from D0 if there is an occurrence of a new diagnosis that could be an adverse reaction. So this is like a ongoing screening of the electronic medical record to detect a new diagnosis. Another aspect is that in the electronic medical record system, we can screen permanently for drug withdrawal. And then we can check what was the reason for drug withdrawal with a healthcare professional and confront that with a timeline logic. If this drug withdrawal has occurred at the same time that we had suddenly a new diagnosis. Let's say that we had an hemorrhage that had occurred after 1 month or 2 months of prescription of anticoagulants, and then we see that the anticoagulant has been stopped or withdrawn, then we can make confront the timeline logic with the EMR system and see and be able to do it systematically. So this was about our project, and the second aspect is about education, and this is something also that we have developed a lot. In June 2019, we had an international symposium, which was multidisciplinary. This is very difficult to do something multidisciplinary, because if it's multidisciplinary, it's not for me, it's for somebody else. But eventually it worked, and it's solution oriented. I didn't want that we will speak again and again about the risk of medication, but I wanted to come with solution. So the topics were the prevention of medication errors in several environments, in hospital, industry, HMOs, and Ministry of Health, risk communication, especially in opioid crisis, and how to measure the impact of what we are doing, thanks to implementation science and in drug safety. We have addressed special populations initiatives, elderly, pregnancy, children. We have chosen several different kind of anticoagulant, biosimilars, opioid crisis in Canada, patients' right for transparency. So you can see that it was really very wide range of topics, and it was very successful. Everything is recorded in our website of the symposium. As you can see, we had 174 participants and speakers from all over the world, and from Israel, from EMA, from hospital, from FDA, from King's College of London. So what is our program now? We are completely going online, of course. So we have started a hot summer in drug safety with 3 events in July. And we had already 2 summits about drug safety in the COVID era in July and September. We had created like a model, which is tell us a safety case story with a presentation of a case, and then how to prevent this kind of adverse reaction to happen again. And this is really the focus of this TELUS executive case story. So what we want is to have, we had already 2, and we want to have 2 per month, once in Hebrew and once in English. We will organize a seminar on vaccination safety, which is really something that we need, because the campaign anti-vax has already started. And excuse me. And then what is very important is that we have a collaboration set up with ISOP chapter from Latin America, North America, Switzerland, and Italy. So what were our challenges to set up this ISOP Israel chapter? What were our strengths? It's an Israeli ecosystem, which is decentralized, innovative, thinking out of the box. And the fact that Israel is a top digital health country with almost 95% of the data which are digitalized in the electronic medical records. We had a very strong committee and advisory board, and this was very helpful. We are really the first in the world experts helping us. We had partnership with professional associations and non-profit organizations. We had tools, great tools with ISMPs, with my e-reports, and now with Medaware and data. And we had also the needy baby midwives. We had 2 pilot centers and an international network thanks to ISOP and NGOs. So we can say that it does not come from physical capacity, as you can see from my picture. It comes from indomitable will, and I like very much this quote. So this is our network. You can see a lot of people from university, from hospitals and association. And these are our wonderful teams and committee in Israel. And from abroad, we have a representative from health policy with Professor Hervé Lelouet and Peter Pitt, and Nick Sedalis and Ronald much more focused on implementation in hospital and community. What were our challenges? The fact that we lack the support from the Ministry of Health, but we are not desperate. We are still hopeful that it will come. We still have some professional association like the medical, the physician association still reluctant to join us, some of them. We are a very small team. For hands-on activity, we have great advisor, but for hands-on, it's a little bit difficult. And we have a huge problem with finances. The symposium, we had deficit. It's difficult. Finances are really our weak point. Let's say that this is what makes life interesting and meaningful when we will be able to overcome them. We have also, and I can say that with the COVID-19 going online was really helping us to set up a lot of webinars, because it's zero cost, no zone limitation. We can invite people from all over the world. We have started to really have a convinced audience and an active participation from this audience coming to tell us about their safety cases. And the next opportunity is, I hope, to implement our strategy in the we are on ongoing contact with them. They are the ninth best hospital in the world according to Newsweek, and for the second year in the row. They have drug safety as strategic topic, which is really not every hospital doing that. Medaware were already implemented, and they have an innovation center with AI, big data, telemedicine, robotics. They are open to innovation. So after 7 years, we can say that we are definitely on the Israeli map of key actors in drug safety. And if you want to join us for strategy implementation, we have now we have 2 years experience, so we can share with you our strategy. We can share with you our infographic and the use of the application report, and we can share also our educational program. So you can find a lot of information on ISOP Israel website. And thank you very much for attending this meeting. So I'm very glad and very proud to introduce Dr. Gidi Stein, who is the CEO of the company Medaware. Gidi is a physician in internal medicine and also a computer scientist. And he has created this very this revolution, I can say, in prevention of medication errors, and is also part of our scientific committee. And Gidi, I would like you to first tell us a few words about what has triggered you to create Medaware. I think that it's important to share this story with our participants.
Thank you, Ren, and thank you for the opportunity to speak in this conference. So, hello everyone. As Irene said, my name is Gidi Stein. I'm co-founder and CEO of Medaware. Of background, I'm a practicing physician and faculty member in Tel Aviv University, where I teach clinical medicine and other things. And really, I always thought that teaching and practicing medicine would be the center of my life and the main thing that I do. But all that changed a few years ago when a 9-year-old boy just died because his primary care physician simply clicked on the wrong entry in the PUDA menu list of the medications and gave him the wrong drug by mistake. He wanted to prescribe the boy with Singular, which is a drug for asthma, but by mistake he clicked on the entry which was Syntrom or warfarin, a very potent anticoagulant. Basically, all of the current available systems at the electronic medical records at the pharmacy have failed to identify that this is just the wrong drug for the wrong patient, and the boy fell off his bike a week later and died of intracranial hemorrhage. Now, when hearing about this tragedy, I thought that this could well have been happening to me as a prescriber, or God forbid to one of my kids, because it's not related to bad judgment on part of the physician. It's a typo, and the mere thought that a typo can kill really led me to think of what can we do to make sure that this doesn't happen again. And if you look at the literature, and anyone who's practicing medicine is well aware that catastrophes are just behind the corner. There are literally hundreds of thousands or even millions of prescribing error, medication-related errors, and different kinds of medication-related risks that harm millions of patients every year around the world. And this translates not only to lives lost, but also to billions and billions of preventable, wasteful healthcare costs every year around the world. The current solutions that are basically meant to deal with this problem are mostly rule-based systems that try to target such as allergies or dosage errors or drug interaction errors. But there are several flaws with these type of solutions, mainly because they are rule-based. And that means that they are basically composed of hundreds and thousands of different tools that were manually curated by pharmacists and physicians in different organizations to create a database of potential harm. But these databases, although alert on many of the potential errors, are also alerting on many things that are not errors. A huge amount of false alarms, more than 10, 20, even 30% of all prescriptions are flagged by these systems, and most of these flagging, more than 95% of them, according to the medical literature, are false alarms. And this drives into what is called alert fatigue, in which physicians and patients are exposed to harm on a daily basis. And not only that, most of these solutions are centered around the prescribing event and the dispensing event. But we know that many of, or most even of the adverse drug events or harm that is associated with medications are not happening or harming the patient at the moment of prescribing, but later on developed during the process of treatment over time. These are evolving adverse drug events and contraindications, that these basically are the most hazardous ones. And these are basically uncovered by the systems out there today and really keeping patients exposed to harm on a daily basis. But this is not new. And the situation in which many of the errors are uncovered by the systems today, and that the systems are generating a lot of false alarms is not really new. But the magnitude of the problem is much more today than it was 10, 20, 30 years ago. And there are several reasons for that. One of them is that when we treated patients 20 years ago, each physician treated a very low number of patients for a longer duration of time. And these patients had very thin charts, maybe a blood test once a week, or for inpatients, or once a year for outpatients, maybe a few visits, and that's it. An intern can learn by heart the full medical record of a patient within 10 minutes, more or less. And a physician on call in a busy internal medicine world received maybe 6, maybe 7 new admissions every day. Today, 20 years later, every primary care physician treats about 2,000 patients. Each patient has gigabytes of data of EMR and lab results and vital signs, the visits, specialty, just a huge, huge number of elements in the medical record. And the same intern from 20 years ago now has to deal with 15 new admissions every night, each of them with this tons of data that he has to memorize by heart, obviously impossible. And the aggregate of it makes it almost impossible for a single individual physician to learn by heart the patient's profile completely and understand which medications are right or which medications can be problematic. And along that comes the number of new medications that enter the market every year, making it, and the guidelines that change twice a year, making it almost impossible for a single individual to grasp all the data and all the understanding in just one brain. And this obviously calls for much higher percentage of prescriptions and much higher percentage of errors that are associated with these medications. But this also changed the way that we treat the patient. If this is what looked like a grand round in a medical department 20 years ago, maybe not as good looking physicians and nurses, but definitely centered around the patient, talking to the patient, physically checking the patient, and then passing a judgment or diagnosis and treatment procedures. Today, it looks completely different. Today, this is how grand rounds look like, unfortunately. And the only one missing from this scenario is the patient, because all the physicians are doing is looking at the patient charts in the computer, trying to figure out of these hundreds of thousands of data elements, what's going on, by ignoring completely the patient and his needs. And this really exacerbates the likelihood of erroneous prescribing, putting patients at risk, and adverse outcome related to maltreatment. So with this in mind, we thought, really, how can we do it differently? How can we change the way that we practice medicine and provide a safety net for physicians when prescribing medication to make sure that they're not harmful to their patients? So we thought that if rule-based systems fail, let's try a different approach. Let's use machine learning or AI or smart algorithms to really crunch millions of electronic medical records, identify what are the normal, quote unquote, behavior patterns of physicians treating patients in different clinical scenarios, and identifying outliers to these behavior patterns as potential errors and flag them at the point of care. And because we will flag only outliers, we can assure that the number of alerts will be very, very small. We just have to make sure that they're really clinically relevant and up to speed. So we partnered with a group of David Bates from Harvard Medical School, and which tested our system retrospectively and published 2 articles, one in 2017 and another one last year in 2019, validating or testing the accuracy and relevance of our system. So these retrospective studies, they analyzed almost 800,000 patients from the outpatient clinics of Mass General and the Brigham Women's Hospital, and followed through from 2012 to the end of 2013, and included basically all the data, all the structured data in the medical record. 50% of the records were used for learning of the algorithm, and 50% used for testing. And a sample of random 300 alerts were selected for review by the clinical team of the research group, and validated by medical experts for accuracy, validity, and clinical usefulness. So out of almost 400,000 patient records, the 50% that we used for testing, we found more than 15,000 potential errors with more than 75% accuracy and clinical usefulness. And in a follow-up study, we found about 11,000 errors with almost 80% validity and or 60%, 63% clinical usefulness. And almost 70% of the alerts that we generated were unique to our system. And this really translated to about 1 in 1,000 prescriptions for outpatients, really a very, very low alert burden, but almost 75 or 80% accuracy. And this is practically unprecedented in decision support tools. The second publication by Harvard was also a pharmacoeconomic one, in which the monetary usefulness of the system was assessed, meaning how much direct cost can the system potentially reduce, putting aside litigation, only direct cost. And the estimation was that we could have saved $1.3 million for the outpatient clinics of Harvard just by applying the system for the duration of the study. And this is, again, just direct cost and a very, very conservative estimation. As a follow-up to these retrospective studies, we wanted to see how does our system work in real time. And for this, we've partnered with Sheba Medical Center, named by Newsweek one of the 10 leading hospitals in the world. It's a 17,000 bed monster, really one of the best hospitals there are, and tested to see in one medical department how does our system perform and what are the outcomes. So in this prospective study, we had fully integrated with the EMR, the local EMR and workflows of clinicians in an inpatient setting, a 38-bed internal medicine department, and again, about 1.5 years of follow-up after a running period of the system. And again, the alerts that were generated, all of them were validated by medical experts from Sheba Medical Center for accuracy, validity, and clinical usefulness. And after analyzing almost 80,000 medical records from medical orders from 4,500 admissions of 3,000 patients, we generated only 315 alerts, 0.4% of prescriptions, very, very low alert burden. And only 40% of the alerts were generated at the point of prescribing, and most of them, 60% of them, were generated following post-prescribing, post-dispensing, in the monitoring phase, when an adverse drug event or contraindication arose or evolved once the patient was already admitted. And as an improvement to the retrospective study, more than 85% of the alerts were clinically valid, and most of them clinically useful. And 43% of the total alerts actually caused a change in physician practice within minutes, i.e., the physician either stopped or raised or changed the medication within minutes following the alert that we provided. And this is really, indeed, unprecedented in decision support systems ever. Now, just to give a flavor of what that means that every year we stop physically about 25,000 errors in Sheba Medical Center every year. And just as a ballpark number, the average cost, or low average cost of an adverse drug event in an inpatient setting is between $3,000 and $20,000 per event. And here we stop 25,000 events per year. Huge number, but most importantly, saving lives and reducing harm. And to conclude, this study shows that outlier detection based on machine learning and statistical methods generates clinically relevant alerts with good physician response and low alert fatigue in a live, busy hospital setting in Israel. Thank you very much.
Thank you so much, Gidi. I'm really very enthusiastic about MedAware, and I'm always inviting Gidi because I think that this will become, I hope as soon as possible, this will become the standard of care. Now we will go to our next speaker, if he is there already.
Okay, I'm logging off. Thank you very much for the opportunity, and see you soon. Bye-bye.
Thank you, Gidi. So we are now moving to our next presentation. We are very, very proud to welcome Professor Gideon Koren. Gidi is Israeli and Canadian. He's a pediatrician and a clinical pharmacologist. He has created in Toronto Mother Risk International. He will tell you a few words about that. And he has written 15 books about drug safety and thousands of articles. He has received many awards from all over the world. And he came back for our great benefit to Israel 6 years ago, and he created Mother Risk in Israel. He's also a theater play writer for children and a composer. And I'm very proud to say that he's member of a scientific committee and advisory board. Please, Gidi.
Thank you so much, Irene. I hope my mother could hear you. It will give her big pride. As you understand from the name Mother Risk, it deals with the risks of pregnancy, of medications, among other things, infections, medications, environmental agents, to the unborn baby and to the mother. This is clearly a population which is neglected and orphaned. Most drugs are not prepared for pregnant women, and actually companies don't want to touch it because of the medical legal aspects. I just declare that I don't have any conflict of interest to declare regarding this particular presentation. Here in Gideon Koren #1, I give you a little background. I was in Toronto when I realized in 1985 that really those questions, I took a medication in pregnancy and I did not know I'll be pregnant. I need to take a medication. What will happen to me and my baby? That no one really answered those questions. That's how we started in 1985 to extend information and counseling to pregnant and expecting women. About 30 years later, I extended the program to Israel, but there is now Mother Risk also in Korea. There's one in Japan. And actually in Israel, there are now 5 sites that do this counseling program. We overall, because we interview moms and receive from them all the information, it's the basis for prospective studies to see if these exposures cause a problem or not. And because most drugs are not designed for pregnancy, and because of the clear ethical issues, to date, no one can take a pregnant woman to give her a drug just to see the results. Of course, we do it with animals, but there's a lot of complexities why animal studies do not tell us what will happen in humans. We published a lot. We have about, just an example, 18 papers published in New England Journal of Medicine about safety or risk of medications. And we trained over the years students from about 45 countries, both physicians that learn this, or graduate students doing their doctoral thesis. As you see, Koren #2, through this work, we could have collected large series prospectively, for example, showing that fluoxetine or Prozac is safe in pregnancy. We extended to other methods, to meta-analysis, combining all the world literature. This is a very important method, as for example, when the oral contraceptives entered the market, there was a big fear that they will influence the genital development of boys because of the hormones. And actually, our large meta-analysis showed that that doesn't seem to be an issue, for example. There's no increased risk. On the other hand, because of these large series, we could show, for example, that lithium is a human teratogen, causing cardiac malformations. But it goes beyond medications, the carbon monoxide, of course, the gas carbon monoxide. In cold countries like Canada, a lot of women and men are poisoned by carbon monoxide. And the question is, what does it do to the pregnant woman and to her baby? And we show that it does affect the brain development of these babies. And I want now to spend most of my presentation on a specific example to show you the need for these research tools and really how pharmacovigilance is critical in pregnancy. The drug is dihydrogesterone, digesterone. It has several commercial names. One of them is Dufaston in some countries. And the drug is an old drug, amazingly, since 1961. It's indicated, it is a progestin, and it's indicated for threatened or repeated miscarriages, luteal insufficiency, dysmenorrhea, and other conditions. Repeated studies showed that it works well, at least as good as micronized vaginal progesterone. And it's very good because it's taken orally. However, interestingly enough, although it's on the market since 1961, as you see here in red, fetal safety is only sparsely investigated. You may ask yourself, how come? We're dealing with pregnancy. Well, The sad truth is that for fertility experts, the end point of their studies is almost always whether the woman succeeded in becoming pregnant, and their reports about the outcome of pregnancy are very sparse, very, very sparse. Indeed, because it's a progestin, maybe because we and others show that oral contraceptives pills are safe, people assume that dydrogesterone is also safe because it's a progestin. However, as you see here in red, because dydrogesterone is substantially more potent than other progestins, one cannot extrapolate from fetal safety of oral contraceptives to dihydrogesterone. And now I turn you to the FDA in 2017. In August 2017, there was a petition to the FDA to explain why dydrogesterone was removed from the American market. This is a citizen petition, which is an American mechanism to find out if things are safe or not. In its official response, the FDA told readers, and this appeared in the FDA registrar, that the withdrawal was not due to safety issues, but rather commercial issues. And in there, the FDA declared that it failed to show safety concerns. But you see here in red, with lack of studies in the peer-reviewed literature, how did the FDA say that DID does not have a safety issue? So let me show you the methods and why we did this study. Maccabi is a very large HMO in Israel, covering over 2 million members. The question came to us because there was a study published from the Gaza Strip, I will relate to it a little bit later, where a study showed in a case control studies, when they looked at babies born with cardiac malformations, that they have twofold more likelihood that mom used dydrogesterone. This was published in the Journal of Pediatric Cardiology, but in all fairness, very few people read it. But then something very unique happened. Lancet, which is the second largest important journal in general, took that study from Gaza Strip and republished it in Lancet, telling the people, big question mark, is it possible that dydrogesterone is not as safe as people thought? The Lancet paper I read, and because this is my area of expertise, of course I was interested, because it was clearly that dufaston or dydrogesterone is very widely used. So I wanted to see how commonly it was used in Israel in these Maccabi services. Because clearly, if very few women took it, I will not have the power to answer any question. But if many women took it, then we may be able to answer the question about fetal safety. We also wanted to know if those women, I am now in methods number 2, whether in addition to dydrogesterone, women took other IVF, in vitro fertilization means, that may affect the development of the baby. So we had 2 cohorts. One cohort of women who took only dydrogesterone, one that took IVF plus dydrogesterone, and those who received other drugs, we excluded them. We came back to them later on for sensitivity analysis that I'll show you. And that moves me to methods number 3. Who were the controls? The controls were women in Maccabi in the same years, starting in 1991, that did not receive any fertility treatment. And we'll come to that a little bit later as one of the challenges of this study. And here are the results. We found out over 8,000 women, 8,508, who used didrosterone in pregnancy, in many cases to maintain the pregnancy after previous abortion, miscarriages, bleeding, and issues of that nature. After we removed those who received other forms of therapy, hormonal therapy, we had almost 8,000 women. This is important just to put it in context. If you collect data on only 1,000 women that took a medication in pregnancy, you have a power merely of showing a twofold increased risk. If the increased risk for malformations is only 50%, namely 1.5-fold, you won't have enough statistical power. In other words, about 8,000 babies has a lot of power. The control group were almost 800,000. So really, really a large group. No one ever did such a study. I did not tell you, but we'll come to it later. By that time, neither the manufacturer nor the fertility experts reported on more than several hundred pregnancies, which have very little meager power to show safety or risk. The babies exposed to didrosterone were slightly lower birth weight, not in a major way, and very, very slightly short gestation. Well, these is cases with subfertility, so this is not surprising. And I'll show you some of the characteristics here of the women and children exposed to didrosterone compared to the control group. And as you can see, they were more likely, about twofold, to receive IVF than women in the general population. And as I said, birth weight was a little bit smaller, as was gestational age. But because the numbers are very, very large, this has the statistical power to show statistical significance. And now I'm coming to the main result. What are the odds ratios of selected malformations in children exposed to didrosterone versus controls? And what you can see here, women that were exposed to didrosterone had about 28% more hypospadias. Remember, these hormones can affect male sexual organs. So this have biological plausibility. As you can see here, the risk was even higher if the woman, in addition to didrosterone, received IVF or other forms of fertility issues. I go down with you to show you that congenital aortic insufficiency was 65% more among those exposed to didrosterone and almost twofold, or 200%, in those that received didrosterone plus IVF and other forms of fertility therapy. And when we continue, you see that overall cardiovascular malformations were higher among didrosterone as compared to the controls, and the risk was a little bit higher when women received other drugs. The same. Now, these results are similar to the study from Gaza Strip that showed in a case control study that children with cardiovascular malformations, there was higher chance of mother to have been exposed to didrosterone and spina bifida, about 2.5 or 2.3-fold more spina bifida when mom was exposed to didrosterone. You may ask why? Well, we conducted a large meta-analysis showing that women receiving progestins have lower levels of folic acid, circulating folic acid. To remind everyone, folic acid control about 75% of spina bifida. So again, there's not just statistics, there's also biological plausibility. And that leads me to our discussion. First of all, I want to repeat here a small case control study from Gaza showing that when mom had a child with cardiovascular malformation, case control study, she had about 2.7-fold more risk that she was on dydrogesterone compared to unexposed controls. So our study agreed with that study from the GABA. And I want now to present to you a case to show you how relevant this, because we are dealing with pharmacovigilance. We're doing this to help women and their families. This case is coming from Europe. It was sent to me after we published the paper I just described to you. This is a family that experienced 2 miscarriages due to incompetent cervix. The babies were normal. When they were checked pathologically, they were normal. So the reason for these miscarriages were anatomical. Then their fertility doctors suggested that they receive dydrogesterone in 2 successive pregnancies. In both of them, there was neural tube defect and cephalocell, which is not compatible with life. So 2 pregnancies with neural tube defects, such as spina bifida, in this case, and cephalocell. In both cases, the woman received folic acid. In other words, she took precaution against neural tube defect and spina bifida. Also, there was not genetic problems with the metabolism of folic acid. So what can it be? Probably, this is a case report showing 2 pregnancies without dydrogesterone that were terminated, but because of anatomical reason of the mother's uterus. In the 2 pregnancies that she received dydrogesterone, she had neural tube defect. So if you want, it's a control group. This is statistically not a proof, but when you combine it with our results of the big study, it shows you that when it comes to patients, these are important decisions. And I'll now summarize for you the hypospadias and the cryptorchidism we showed are known biological effects of potent progestins in male infants. So there is biological plausibility. Cardiac malformations, as I said, was shown in the Gaza study that was combined with Belgium, and the risk of spina bifida consistent with large number of previous studies showing that oral contraceptives lead to increased risk of spina bifida because of lower levels of folic acid. So what are the conclusions? And that's where the pharmacovigilance is so critical. There's no question we need more studies to rule out confounding by indication. Let me explain. One of the criticism against our study was, Professor Koren, you take women with subfertility. Subfertility itself can increase risk for malformations. But guess what? Not for these specific malformations. So yes, that's why we had a control group also with women who received subfertility other drugs. So clearly, this is potential confounder that will need to be controlled. But it's not easy because women with subfertility, most of them do not succeed in getting pregnant. So to collect a group just with subfertility without treatments will not be easy. And now, to ensure that you all remember the holy language of Hebrew, it's just a joke, we thought it's important to have patient information that says Dufaston is an old drug that is quite effective against hemorrhages and repeated miscarriages. However, fetal safety is still being studied, although there are several studies, including a large study from last year, suggesting that there is a risk. The risk itself, absolute risk, is not huge, because in most cases it was less than twofold. So most babies will still be born normal, but some babies may have malformations because of the testosterone. Importantly, some of these can be followed up when the woman is still pregnant. For example, echocardiogram and ultrasound can help rule out both cardiovascular malformations in the fetus and neural tube defects. And at that cases, we can detect those, and if it's acceptable, statistics show that most women, when they are aware in utero of a major birth defects, choose to terminate pregnancy. Of course, it's not true for every country, but here is an example how counseling has to be based on information. We clearly need more studies, but the power of a study with 8,000 women exposed and 800,000 controls give a lot of confidence in the results. I will stop here and I will thank you for listening, and I hope that pharmacovigilance used more and more to help pregnant women and her unborn baby. Thank you very much.
Thank you so much, Gidi, for this really wonderful presentation. And what will be your advice if a woman is calling you and asking you what to do about her miscarriage and if she has to follow this treatment or not?
Yeah, it's very important that for me to mention that many physicians tell women not to take any drug in pregnancy. But of course, this is not an option. Women now increase the age of starting pregnancy, first pregnancy, and starting a family. The age in many countries is about 30, 32. With age, women have more disease and more conditions, from lupus to cancer in pregnancy. So women need medications. It behooves on us to find what's known and to ensure that we give the woman those numbers. Very often, Irene, they come to us after someone scared them to terminate pregnancy. But first of all, what is the evidence? It's important to mention that most medications are safe in pregnancy. The list of medications, such as what I showed you today, is relatively small. Also, not every malformation is a reason for a woman to terminate pregnancy. I'll give you an example. Ventricular septal defect, VSD, in most cases is of the muscular type. They tend to close spontaneously before the age of 2. And even if the baby needs an operation, in most countries today, using modern surgery, this is corrected quite appropriately. So it's important not just to say, no, this is a risk for you, but try to decide the size of the risk and what are the other options. Of course, the decision always should be based on the woman's and family's wish. It goes without saying. But in this day and age that there's so much false news going around, it's very important for us as pharmacovigilance experts, to identify issues, but also to ensure that the health professions, and not just physicians, nurses, midwives, in our case, have the right information. And if they don't have it, they find the source for right information or find the expert in their country that can give them that advice. So this is, in very rough brush, the Bible of counseling, what to do about those risks.
Thank you so much, Gidi. It was really a great pleasure and honor to welcome you in this session and representing the ISOP ISRAEL chapter. Thank you so much and have a nice evening.
Thank you very much.
We have now the great pleasure to welcome Dr. Gil Mileikowsky, last speaker but not the least, and he's someone that everyone should know. Gil?
Yes, how are you? Thank you so much for inviting me.
Sir Gil is the president and founder of the Alliance for Patient Safety in USA and in Israel. And he's obstetrician and gynecologist working in USA for most of his career. And he has really been a game changer in the field of transparency and whistleblower. So today I'm very glad to interview Gil Mileikowsky and ask him to speak about his incredible history. So Gil, you have been mentioned as one of the 20 people who make healthcare better health by the Health Leader magazine in December 2008. Can you tell us why you have been mentioned as such?
Well, first of all, thank you very much for inviting me, Irene. It's a great privilege. What happened was that Health Leaders Media wanted to do an article about 20 people in the United States who have been clearly instrumental in improving healthcare in the United States. They wanted one of the 20 people to be a whistleblower. So they went around and asked, who is the #1 whistleblower in the US healthcare? And slowly but surely, clearly, it turns out that I was the one that was directed to. So the journalist called one of my attorneys who asked me if I was ready to speak with the journalist. I said, sure. And that's how I was chosen as one of the 20 leaders in the United States that has contributed to improving US healthcare.
So what did you do to improve healthcare? Can you tell us your story?
Sure. Like many things in life, it did not happen by my own decision. One day, June 13, 2000, I got a phone call from an attorney I never met, never heard of. She found my name in the Los Angeles Bar Association of Experts. And she asked me a question that sounded so ludicrous. She asked me, Dr. Mileikowsky, do you believe it is within the standard of practice to remove both fallopian tubes of a patient without her consent? So I was so surprised by such what appeared to me a stupid question that where's your case? I asked her, is it in India, in Africa? Where is it? She says it's in the United States. Oh, I said, Texas? You know, in Texas, they're a little radical. Patients and physicians, by the way, are conceiving the possibility of, and they do at times, a hysterectomy on a young patient, 26 years old, with 2 or 3 kids. She says, no, it's in California. So I couldn't imagine it was in a major metropolitan center. So I asked her if it's in Bakersfield, you know, a faraway village. She said, no, it's Tarzana Hospital in Los Angeles. Now, since I was already 14 years at Tarzana Hospital in the Department of Obstetrics and Gynecology, and I was responsible, among others, for supervising complications, I presumed that the case did not happen in my department. So I asked her, was it a general surgeon? Was it a cancer? Was it an infection and peritonitis? And the pathologist found the tube in the specimen. She said, no, it was a pregnancy in the tube following a test tube baby procedure. Now, in Los Angeles, we have a funny expression when somebody imagines a lot of things and has great creativity or creative mind. then we say she must be smoking something, because I've never heard of that case. And we have a very small test tube baby program, maybe 4 or 5 physicians, until the day I saw the chart. The day she showed me the chart, I was absolutely shocked. Every single thing that attorney told me was accurate. Now I had to ask a question she could not ask. How come she knows about it and I don't? Case was filed 3 years before. Until that day, I was absolutely convinced that the United States had the best quality control system, second to none. What I did not know, but learned pretty fast, is that actually the whole healthcare quality control system is one gigantic deception. It's virtual. Because I agreed to testify on behalf of that patient, what happened was that as soon as the hospital learned that I was chosen by the attorney to be an expert, I received a letter from the CEO of the hospital, a very nice guy, telling me that effective immediately, I had to contact him a half an hour before coming to the hospital, at nighttime contacting the head nurse, and I needed to be escorted by security. I've been here 14 years, he's never been concerned about my safety, so I thought it was pretty original. And lo and behold, a few months later, when 3 days after I went to the FBI, I was in a soundproof room on the 17th floor of the federal building in Westwood. This time my office received a phone call from the same CEO, and he asked me to be paged. I called him, and in a trembling voice, he told me, Dr. Mileikowsky, effective immediately, you no longer have privileges in this hospital. I said, fine, I'll see you in court. I had no patient at that hospital at that time, no complaint from any patient against me, no cause of action, no negligence action against me. So clearly, the only reason the hospital retaliated against me, and it's not unique, I learned later on, every single physician, not just in the United States, in Israel, in Belgium, in Australia, in England, retaliated against if they dare to testify against the hospital or against another colleague. And obviously, we cannot have good quality control. And that's how I discovered that the whole quality control system in the United States is fictitious. And I blew the whistle.
So after that, I know that you had a very long story of trials in court, and that you have 2 laws with your names in California, and eventually you won your trials, but anyway, it was still difficult to find another position in any other hospital. Now, can you tell us, why did you create Alliance for Patient Safety? What are the objectives right now of this organization?
Well, the original, I don't know if you see my picture because I don't see it on the screen, so I don't mind. I'm curious to know.
Yes, yes.
Anyhow, the reason actually that it was started was that actually one of the organizations medical organizations in the United States had already a lot of information about me. And I was asked by a lot of people to put my story on the internet. And it became bigger and bigger and bigger. And so the president of the organization told me, Gil, you're taking too much space on our website. You need to create your own website. And I realized that people will listen to patients before they will listen to to doctors, sorry. And so that's why I called it the Alliance for Patient Safety, because that's the whole purpose. The reason I was retaliated against was precisely because I stood up for quality of care. And lo and behold, I could not figure out why a hospital would protect such a negligent physician. It was already a second time I learned by coincidence of such a situation with the same 2 physicians, same hospital. I was on staff. turns out that the more complications, the more errors, the more income for the hospital. So actually what you and I would call a good physician would be a physician that admits patients to the hospital only when necessary or medically indicated, and will only operate a patient if no other choice. But for a hospital, a good physician is a physician that would admit practically all of its patients. Then obviously for you and I, a good physician is a physician that patients go home the same day. But for a hospital administrator, a better physician is the one that has complications, errors, and keep the patient as long as possible in the hospital, so income goes up. And so that's how I discovered that actually the best economic interest of the hospital and the best economic interest of the patient are exactly 180-degree opposed to one another. And that's really how I started to become more vocal. I had total support of the 4 major medical associations in the United States: the American Medical Association, the California Medical Association, Union of American Physicians and Dentists, and the Alliance for the Association of American Physicians and Surgeons. When we got to the Supreme Court on my 3rd case, I have 3 laws under my name, Irene, because the name of the law is based on the name of the plaintiff, not the name of the author, the judge. And something unusual happened in my case. The 3rd case went before the Supreme Court, says the opposite of the 2nd case. And to distinguish the laws, they put Roman 1, Roman 2, Roman 3. Now, before the Supreme Court of California, 20 organizations filed documents in my support to enlighten the Supreme Court about the importance of the message here and the importance of the ruling of protecting what is called the 14th Amendment of the US Constitution and California Constitution of due process. You cannot basically sentence someone before you judge it. Imagine if you hang someone before even proving the person is guilty. But that's exactly what the hospitals do. They basically suspend the physician's possibility to function in the hospital before even judging the physician. They don't care about judging the physician. They want to get rid of the physician. But the hospital is not alone. The liability insurance companies do not want physicians to testify against physicians and against hospitals on behalf of patients. And so that also is supposed to be, according to the Congress, the idea of the Healthcare Quality Improvement Act was the fear of liability in lawsuits by plaintiffs' attorneys will be a balance and check with hospitals to make sure they do the right thing from fear of a lawsuit. But hospitals and insurance companies found a way to basically reduce the effects of any lawsuits. And basically, it's a very tragic situation where there is nobody standing up of major power. Obviously, that's why I created I'm part of a much larger movement of patient safety activists, and I was invited by the Boston IHI, the International Health Improvement Institute, to participate in the first such Congress in Florida in 2010.
And can you tell us a few of the projects that you are dealing with right now in the frame of your association?
Well, obviously, I get phone calls from physicians. I get phone calls from patients. I am invited to speak, like I did last year at your symposium, which was brilliant. I also actually act in a different way by investing in companies that actually create a system to help physicians reduce the errors. One of them that I introduced to you was MedAware with Gidi Stein, who's one of the founders you just interviewed. Another one is Water.io. It's a very interesting company. Here's a fellow, an Israeli high-tech, brilliant mind, that just saw this company, so he has plenty of time. He goes with his daughter from physician to physician, and he's frustrated. Nobody can figure out why his daughter is having recurring urinary tract infection, until he gets to a very well-known nephrologist who does not basically has an opinion based on a medical record or laboratory. He looks at the patient. How unusual. As soon as the daughter walks through the door, the doctor tells her she's dehydrated. Says, how do you know? Well, just look. And he shows him how to detect dehydration without any lab tests or anything else. And then he learned that this is actually a very, very preponderant problem, not only with kids, but also with the elderly. I learned that when I was taking care of my father, and elderly don't tend to want to drink too much. And dehydration is a major problem in pregnancy. If a patient comes in premature labor, the first thing we do is put an infusion with liquids with hydration, and probably 50 to 70% of the time, contractions stop. Obviously, we give other medication to help, but the hydration is extremely important. But Water.io came up with another device, a cup, a smart packaging cup that either sends light or sound or call your cell phone to remind you to drink. Or they developed for Sealed Air, which is the largest company in the world of packaging for drugs. And they are probably going to be the ones that are going to provide the packaging for 600 million vaccinations for the United States government for corona. It's very important that during the transport of medication and food and other perishable material, that the temperature will be at the appropriate level during transport, whether it is in a truck, on a boat, on a plane, or in a pharmacy, wherever it is. Otherwise, the drug or the food will be perishable. Water.io developed such a device that records it all along and provides that information. And this is now part of a package of Sealed Air. They also developed other methods that are fascinating when the FDA requires, for instance, a very large multinational pharmaceutical company to prove that the powder in the bottle has been mixed. So by having a sensor on the pressure at the bottom of the cup, when there is enough pressure, then you know the powder has been mixed, and so the medication becomes effective. Also, for instance, Sanofi has a drug that's very toxic that requires patients to drink a lot on the first 2 days of taking the medication to reduce the toxicity. So they actually provide with the drug a smart cup that lights up and provides you the information to encourage you to drink. Another company is Pill Tracker. I'm on the board of Pill Tracker. Pill Tracker actually developed a device which looks very much like a cell phone. Only at the bottom of the cell phone, there is a dispensary of drug. In order to open the dispenser, the box, the patient needs to put his fingerprint. So the patient is the only person that has access to that medication. Then there's also a camera that allows a nurse to see the patient does take the medication properly. If the patient forgot he took the medication, the box will not open until a reminder will come 3, 4, 6, 12 hours later when the patient has to take the medication. This device was developed at first, at this point, for clinical trials, because if a patient misses a drug or doesn't take a drug, well, that's problematic because then there's no valid clinical trial. It delays the clinical trial. New patients have to be enrolled. And so it's extremely important to have accurate data. Right now, what we do, and still pharmaceutical have to do, is measure in the blood whether the patient took the drug or not. That's too late. You want to make sure the patient took the drug at the right time, at the proper time, so they see if it's effective or not. So there are many ways that I can be effective, not just by being a patient safety activist, but also by promoting companies like TytoCare or other companies that allow patient empowerment. The more the patient is knowledgeable, the more the family of the patient is knowledgeable, the more helpful they are to the healthcare team to be sure to reduce the risk of any mistake, but also that the proper management of the disease or the pathology is done so that actually the patient, the family, the doctor, the nurse are integrated into one happy team Often problems occur when there's a lack of communication, a lack of information on the healthcare team or on the patient side. So we often talk about patient compliance. Well, there's no possibility to have a patient compliance if the patient doesn't understand how important it is for the patient to do a certain task that a nurse or the doctor asks. And it's very helpful to have a daughter, a son, a father, a wife, a sister, and so forth to coach the patient and make sure that things do well. I think we reached 20 minutes.
Yes, a last question for you. How do you see that? What kind of recommendation you would like to send to the Ministry of Health, to the drug agency in the world that will help to solve this problem?
Well, I want to caution everyone that digitalization of healthcare does not necessarily mean better quality care. As I gave you the example earlier, that physician immediately saw at a distance that the daughter was dehydrated. Clinicians must be clinicians, not robots. And also the biggest problem is that there is a tendency of the code of silence, which is very well known, and it's not limited to healthcare. Digital healthcare can provide a facilitation of hiding information. The biggest problem for a doctor, for a physician, doctor who is a director of a hospital, who wants to make sure that the quality of care is achieved, is getting the information from the staff. Staff will not provide information if he or she, a physician or a nurse or a pharmacist or anybody else, did a mistake. Human nature will self-accuse and propagate information. I did a terrible mistake, it's my fault. No, there's a natural tendency to hide mistakes. Digital health can be helpful in studies like Dr. Koren just showed. Medaware, I believe, has a great device, but we cannot just depend on that and believe that, for instance, an X-ray will tell us everything. I remember as a resident, I saw a CT scan of a patient, and when we opened the abdomen, there was a huge, huge cancer. CT scan didn't detect it. So we have to know a lot, but always understand that it's only part of a bigger picture, and always keep an open mind and not forget we are clinicians first, and communication with the patient, communication of the patient, responsibility of the patient and the family to make sure to help the healthcare providers to be in the right direction and not treat one patient instead of another or operate the left leg instead of the right leg. You'll be surprised how many wrong surgeries are done to the wrong organ or wrong size. It's pretty tragic, but it helps. It still helps today.
Thank you so much, Gil, for this inspiring history, for this courage that you have shown and you are showing all the time. We are now closing our session, the Israeli chapter of ISOP, and I was very, very proud to welcome you as well as all our previous speakers. Thank you so much.
Thank you very much, Irene, and I'd like to salute your energy, Irene, and your passion.
Thank you.